And now we are shifting to the next speaker, one of the rising stars in the field of pathology. وأنا متأكد إن هي تبقى محاضرة رائعة كالعادة. One of the best lecturers, Professor Dina Semman, and will speak about cervical cancer pathology, what really matters.
Okay, good evening, everyone. Firstly, let me express my deepest gratitude to the Leaders Academy, all the team, and Professor Dr. Ahmed Abdelhadi for the generous invitation. Today, I will be talking about the pathology of cervical cancer and what really matters for the clinician, the surgeon, and the oncologist. So we all know the burden and how many cervical cancer cases worldwide, and we know also how the cases have declined recently owing to the vaccination and to the screening. And it has been established that the majority of the cases are HPV dependent, whereas the minority are independent. Again, the majority are the squamous cell carcinoma and the minority are the adenocarcinoma. Today I will be taking you into a quick journey through the clinical journey of cervical cancer from biopsy to treatment all through my talk. And this will start with the initial biopsies from the cervical cancer that we receive in the pathology department, then into the integrated staging that is done by the combination of the radiology and the pathology that dictates the decision whether the patient is candidate for surgery or for chemoradiation, after which the surgery again is dictated according to the whether the patient is fit for fertility sparing or no. And then we meet the cervix one more time in the pathology lab after resection to assess other parameters to stratify the cases into high risk or intermediate risk. So this is the first encounter of the pathologist within the cervix. We usually receive one of these, the most commonly of which are the colposcopically directed punch biopsies. So in these punch biopsies, we can provide you with the histological type of the cancer. Less commonly endocervical curettage, again to provide with the type, and the excisional biopsies, whether called the knife cone or the leap, and these can provide some more parameters beside the histologic subtype, which includes the depth of invasion, the horizontal spread, and the third dimension. These are the measurements of the tumor, the lymphovascular status, and the margin status. One more thing from the biopsy specimen is that pathologists can tell you whether the tumor that you are facing is an HPV dependent or independent using the P16 immunohistochemistry. And by P16 we always refer to only to HPV dependent when we have the strong diffuse block staining of the P16. Together all these data combined with the radiologic data, the MRI that includes the extent of the soft tissue tumor, and the PET-CT which indicates the status of the lymph nodes, and the clinical examination, you go for the integrated FIGO stage that afterwards dictates the next step. And these are the updates. I believe everybody is familiar. It's 2018 and we are 2026. The only thing that I would love to shed the light on is that the lymphovascular invasion in the cervical cancer is not included like the endometrial carcinoma. We have all heard about the 2023 of the FIGO and how the lymphovascular invasion plays a role in the upstaging and downstaging. It's still important in the assessment of the tumor, but it does not affect the stage. Okay, so how does the pathology report dictate the clinical decision? This is what I have mentioned a while ago. According to the stage using the size assessment and the radiologic, we go into one of those tracks for early cases if fertility sparing is required or non-fertility sparing is required, and in advanced stages the surgery is skipped and the patient is candidate for adjuvant chemoradiation. Okay. Another thing is how the pathology again dictates the decision when it comes to fertility sparing is that lymphovascular invasion plays a role in whether the patient would be a candidate for simple cone biopsy, radical trachelectomy, simple hysterectomy, or a lymphadenectomy, depending on the stage that includes the size and also the lymphovascular invasion dictating the FIGO stage. Then after the surgery comes the second encounter of the pathologist with the cervix, and we receive the specimen that the surgeons decide to have to provide you with some more data, including the other margins, the parametrial assessment, and the pelvic lymph nodes if we receive any from you, to produce a report including those parameters that some of which stratify the patients into high risk, such as the positive surgical margins, metastasis in lymph nodes, and parametrial extension or parametrial deposits, and others that may pose the patient into an intermediate risk that include the tumor size, the depth of stromal invasion, and the presence or absence of LVI. Visiting the latest NCCN of the 2026 and the latest 𝐠GO-ESTRO-ESP of the 2023, they have agreed that these are the really important items to be reported into the pathology report, including the WHO type, the Silva pattern, the P16 status, the measurements, the LVI, the margins, and the nodal status. And I will be going through each and every one from the pathology point of view to see through these what the oncologist is looking for and what the pathologist can provide. So starting with the types of the cervical cancers, according to the latest GYN pathology, genital tumors of the WHO, we have a number of subtypes. As I have mentioned, the majority are the squamous cell carcinoma, then comes the adenocarcinomas, and then a number of other tumors which are rare, including neuroendocrine tumors and others. What really is of importance now is whether the tumor is HPV dependent or it's HPV independent. And again, we are using the P16, which is the surrogate marker for the HPV. Nowadays, it's easier than the PCR, the molecular testing, so it's supposed to be done on all cervical cancer. The idea of the subtype, or the histological or the morphological subtype, is not the idea of concern nowadays. It's only matter to us as pathologists to recognize the type of the tumor, but actually to clinicians, they are interested or they care about to know whether the tumor is HPV dependent or independent. We have the majority of the squamous as HPV associated, majority of the adenocarcinomas as HPV associated, a minority of aggressive adenocarcinomas, including the gastric, the clear cell, the mesonephric, and the very rare endometrioid in the cervix as HPV independent. Okay. And then sometimes we opt for immunohistochemistry to do some differentiation. When we have poorly differentiated the squamous cell carcinomas, we can go for the P40, the P63. Sometimes when we have glands and we are not sure of whether it's Mullerian in origin or gynecologic in origin or it's metastatic, we can go for the PAX8. If we are suspicious for neuroendocrine, we can use the neuroendocrine panel, including the synaptophysin, chromogranin, CD56, and less commonly used the INSM1. Again, on the same specimen, we can use the P53 and the ER and the PR that play the role in confirming those subtypes. These are subtypes of the adenocarcinoma. I've just mentioned that the usual type is the only one that is P16 positive. The rest are P16 negative. The gastric type usually have P53 mutation. The rest are wild type. All of these are ER and PR negative since they are cervical in origin. Then I go to the next question. We receive cervical biopsies every day, and some unfortunate cases, they have cervical masses with lower uterine segment extension, and we get the question of, tell us, is this primary cervical or primary endometrial? Now we are starting to get used with the routine use of this panel, which is the P16 together with the CEA, the ER, the PR, and the Vimentin, to differentiate between primary cervical carcinomas or versus primary endometrial carcinomas, with a few exceptions. As you can see, the P16 goes as block positive in the cervical, together with the CEA, the ER, the PR, and the Vimentin are positive for endometrial. But always bear in mind when talking about endometrial that it's not only endometrioid. We have some exceptions in serous endometrial and clear cell carcinoma endometrial. So in serous carcinomas that are endometrial in origin, for example, you can still have P16 block positive stain, and you can still have, but the P53 is mutant, and this is very much helpful to differentiate. Okay, then if we have a serous carcinoma that is extending from the endometrium to the cervix or from the cervix to the endometrium, despite the fact that there are no published papers enough to designate, but there is a general consensus that the clinicians consider the serous carcinoma as rather metastatic or from direct extension, whether from the endometrium or the ovarian rather than cervical. Another question that we, to a lesser extent, face, whether the mass is cervical or vaginal. Discussing a squamous cell carcinoma, according to the VIGO, a vaginal lesion involves the external os of the cervix, should be considered cervical cancer and treated as such. Okay, now we come for the next, which are the DOI in the measurement, which play a really important role in the staging in the VIGO 2018, supposed to provide the exact depth of invasion, either in terms of inner third, middle third, and outer third, or to measure exactly from the lower edge of the high-grade lesion, high-grade squamous intraepithelial lesion, the high-grade lesion, to the deepest extent of the tumor. And this is how we are supposed to do the measurements. We have the DOI, or the depth of invasion, as you can see denoted by the arrow A, versus the horizontal width and the third dimension. DOI is the one of concern. The other two in the VIGO 2018 are mainly to assess the size of the tumor. Now one more parameter is the Silva system that is supposed to be used with the HPV adenocarcinomas. This is actually a grading system where the traditional glandular grading system does not work anymore. The Silva A, B, and C is based upon how the glands architecture are, the presence or the absence of lymphovascular invasion, and the presence of desmoplastic stroma. And why this is really important for clinicians, because it was found that there is some relation between the risk of lymph node mets and the pattern of the Silva grade. Okay, the pattern A has 0%, the pattern B 1 to 2%, and pattern C has 23.8%. Dr. Magda, excuse me, have your place in the panel. Okay, I would love to welcome Dr. Magda Hassan. She's one of the leading experts in GYN pathology, and I have the pleasure to be one of her students, actually. Okay. The next question is really a debatable question all the time, which is the lymphovascular invasion. Lymphovascular invasion is something that is really important to the oncologist as much as to pathologists, and we've been discussing in a while how much lymphovascular invasion has really inter-observer variability, and you will always need an expert pathologist to evaluate this. Sometimes you can refer to immunohistochemical aids to help in this. The quantification, however, of lymphovascular invasion, whether we have one vessel, two vessels, low focal or extensive, more than 5, less than 5, is not an issue in the cervix as much as it is in the endometrium. And what's the really importance? The LVI gives an idea about the risk of lymph node status, and thus dictates the whether the frozen section is indicated or no. Again, gives an idea about the fertility sparing and surgical approach, if it is feasible or the patient is high risk, and again can dictate the adjuvant radiotherapy in the case. Okay, we go for the margin status. Again, commenting on the margins in the cone biopsies or the LEAP and in the surgical specimens that are resection are really of important value. It dictates the next surgical step, the feasibility of fertility sparing surgeries, the adjuvant therapy as a trigger for chemoradiotherapy or no, and has a role in the risk stratification. As we have just mentioned, its involvement is one of the high-risk groups. The lymph node, again, we are promoting the idea now of doing sentinel lymph nodes. I believe it's not done in many centers in Egypt, but if the stain is there, we can do more sentinel lymph nodes in frozen biopsies, and afterwards we can do the ultra staging using maybe the pancytokeratin to detect the micrometastasis that affects actually the stage and cannot be detected, but this will be applied on later routine paraffin section, not in the same setting of the frozen section. That's the sentinel lymph node mapping algorithm introduced by the NCCN of the suspicious lymph nodes and how to detect whether to do the mapping or no. Okay, I come to the last point of today's discussion, which is the biomarkers. If I'm talking about the cervix and the biomarkers, I would love to segregate them into actually the problem solvers. These are the markers that we pathologists use to reach the diagnosis. The systemic gatekeepers, these are the ones that you as oncologists ask us to do for the therapy, and the risk predictors, these are the ones that we use to a lesser extent. Here comes the P16, which is the indispensable marker that we have mentioned that we want to do it for every cervical cancer patient. Then comes the other ones like the P40, P63 synaptophysis that might help us in the diagnosis, and the other markers that help to allocate the anatomic primary origin like the P16, the ER, the PR, the CA, and the Vimentin. To a lesser extent, the P53 and the Ki-67 to predict the aggressiveness or the behavior. Sometimes the P53 can help us reach some diagnoses too. And then the therapeutic targets, including the PD-L1 and the mismatch repair for the pembrolizumab, Keytruda, and finally the HER2 cases for the trastuzumab deruxtecan. This is the slide that I would love to end my talk with, and again shed the light on and the stress on the idea that immunohistochemistry results are not only operator dependent and interpretation dependent, they are pre-analytics dependent. And by pre-analytics we mean the process that occur before we see or we do the staining. And this includes actually something that surgeons or whoever take the biopsy does, including the fixation. If we do not receive a very well fixed specimen, the results will not be reliable, and the patient therapy would definitely be affected. So my advice it would be that a biopsy specimen should be fixed from the cold ischemia time to the moment it is put in neutral buffered formalin. This should not exceed an hour, preferably in the first few minutes. Okay, the fixation duration itself should not be less than 6 hours, or not more than 72 hours to bring reliable results. Now I come to the end of my talk. Thank you so much for your attention. Thank you so much for
Professor Dr. Dina, for this nice presentation. I'd like to ask you about the accuracy of central lymph node in cancer cervix. You know that if central lymph node is positive, I am a surgeon, I report this case and refer the case for chemoirradiation. So my question is accuracy of a frozen section in central lymph node.
Okay, let's agree on something. Frozen section generally is a difficult approach, or let's see, it's not as clear as routine paraffin sections for us as pathologists when we examine, okay? But the idea, if the metastasis is there, it's there, especially if it's macrometastasis. But there will still be a risk for missing micrometastasis, and all the frozen sections we submit for paraffin, and this is a consensus among pathologists. يعني, sometimes I can tell you that it is negative and it turns out to be positive. وهنا ياتي رول الالترا ستيجنج. هو يعني خلي بالك حضرتك الالترا ستيجنج انا مش هقدر اعمله على الفروزن يا دوبك هاخد سيريال ولا اتنين وبص عليهم بالاتش ان اي وادي حضرتك الفيدباك. لو عندي ماكرو ميتاستاسيس وقادره ان انا اشوفه واعلق عليه well and good. لو قدرت القط مايكرو ميتاستاسيس I will do this, but there is still an incidence that I might miss something in the frozen section and report it later on in on the paraffin blocks, especially with the aid of the immunohistochemistry. Isolated tumor cells بقى من الحاجات الصعبة جدا. We can never ever pick up يعني by naked by microscope H&E without using pancytokeratin, but I believe that isolated tumor cells to you is not as important as the presence of micrometastasis. يعني does not affect the stage of the patient. صحيح؟
يعني you advise يعني دلوقتي أنا شغال كويس واديت السنترال ليمف نود دلوقتي فروزن ومستني دلوقتي النتيجة. لو هو دلوقتي النتيجه مثلا هل الجروس يعني هل هتبين لي النتيجه على طول ولا احتمال كبير يقول لي ويت فور بارفين؟ انا مش بتكلم على الماكرو مثلا الماكرو ميتاستاسيس، انا بتكلم على الجروس ليجن نفسه في السنترال ليمف نود.
جروسلي؟
بالظبط كده.
لا هو احنا تقصد
يعني
اندر الميكروسكوب.
لو ماكرو لو قلت لي بوزيتيف امشي اكمل الحاله انا ابورت يس واصحي العيان عشان ياخد كيمو ايراديشن. اما لو حضرتك قلت لي ويت فور بارفين انا هبقى في حيره، انا هكمل الحاله ولا اقفل العيان عشان اويت فور بارافين؟
ما انا بكلم حضرتك بقى من واقع اللي بيحصل. sometimes we say wait for paraffin، يعني sometimes it's equivocal. فممكن دكتوره ماجده برضو تقول رايها في نقطه الفروزن دي.
هي فعلا الديتكشن بتاع المايكرو ميتاستاسيس on the basis of paraffin would be difficult. وفعلا محتاج waiting for paraffin، لان احنا ساعات بنحتاج immunohistochemistry which is not available في الاوبريتنج ثياتر، ولا نتائجها هتطلع وين في الاوبريتنج ثياتر. اوكي، في حاجات ممكن تبان في الفروزن as if it is malignant and it's not. ممكن بيبقى في ساينس هيستوسايتوزس وتدينا منظر مختلف عن الباك جراوند بتاع الليمفوسايت erroneously diagnosed، بالذات لما يكون حد بيجنر او كده ممكن جدا تبقى misleading. I prefer ان احنا we wait for paraffin. I prefer this من ناحيه ان احنا ممكن نحتاج immunohistochemistry وده مش هيبقى ريزولد اثناء الفروزن، محتاج ان احنا نبقى quite sure that this is epithelial cell and not a histiocyte or a mimic that cause misdiagnosis of malignancy. This is the point. انا اشتغلت على السنتينل ليمف نودز وكان في داي معينه بيحطوها يس بيحطوها، وكان يعني حد من الاميننت بروفيسورز يعني دايما بيشتغل حتى على في حالات البريست اند سو اون اللي بتدي لون، هو ده اللي بيعتبره بوزيتيف. فده بيعضد الموقف تحت الميكروسكوب.
هو الاندوسيانين مش عشان تديني هي بتديني لوكاليزيشن اوف سنتر يعني انا بشتغل دلوقتي
لا غير اللوكاليزيشن في بقى يمكن صبغه ثانيه بس
بعمل لوكاليزيشن بدخل في اللاباراسكوب اشوف الصبغه او الليمف نود اللي واخد الاندوسيانين في اللاباراسكوب باخدها بنزلها في الفوزن بعد كده.
يعني خليني
بقى بعد كده الفوزن يقول لي ايه؟ لو طلع بوزيتيف بصحي العيان اقول له لا خلاص مش هكمل العمليه هاخد كيمو. لو قال لي بقى ويت فور بارافين انا اصحي العيان ولا اكمل العمليه؟
اتفضل.
هو طبعا في ديفرنت سيستمز، لان اللي انت ده جزء ام دي تي، فلازم تو ستاندردايز وات يو ار جوينج تو دو. يعني مثلا على سبيل المثال في المانيا وبرضه في اليابان كان نفس الكلام كده، you will do sentinel lymph node and you will wait for paraffin. There is no rule for frozen section to take a decision. وده based on their studies لما جم عملوا بدايات السنتينل ليمف نود، وان هم يشوفوا، لان انت في الاساس انت بتتكلم راديولوجيكالي this patient is not negative عشان تدخلها في sentinel and early stage. فاذا كانت السنسيتيفيتي بتاعت الراديولوجي كومباربل للريزلتس بتاعت الفروزن كومباربل للريزلتس بتاعت البارافين، يبقى يو كان جو ثرو ان انت تعتمد على الريزلتس بتاعت الفروزن زي ما بيعملوا مثلا في اليونايتد ستيتس. لكن في يوروب وفي جابان لا، يو شود ويت فور بارافين. طب احنا في مصر ما عندناش السنتينل ليمف نود، هنعمل ايه؟ If we are going to introduce this service we should start first that we will do it in experimental settings. يعني هنعمل السنتينل ليمف نود وهنعمل ليمفادينكتومي ونشوف السنسيتيفيتي بتاعتنا بالنسبه للراديولوجي بالنسبه للفروزن، ودي بتختلف من سنتر للتاني. بس انا اعتقد حتى في معظم السنتر they are waiting for paraffin. انا برضو عندي سؤال تاني بعد اذن حضرتك دكتوره دينا.
طبعا حضرتك اتفضل.
Usually when pathologists ask for immunohistochemistry we usually have an itch on the back. احنا يعني ما كناش بنسمع الاميونوهيستوكيمستري من كذا سنه، اعذريني لجهلي، لان انا لما بتكلم مع الباثولوجيست بتاعي بينظر لي نظره شظرا كده، انت مالك يا اما ما تعمل الماركر اللي بقول لك عليه. بس في الاخر انا بتكلم ليه؟ لان asking for one marker usually means I usually have to wait for extra 3 weeks, and when I have a panel which is expensive and waiting for 3 weeks to have the results, usually they ask for another panel and so on. وحتى هنا في المحاضرة، وأنا طبعا بحب محاضراتك جدا، but I didn't see an H&D, I didn't see what are the pathological features that you can diagnose by it. Is it cervical or endometrial? أنا حاسس إن في شوية negligence إن إحنا نقول البيكتشر إزاي، وفي إلى حد ما we are relying on immunohistochemistry. وهنا أنا I will not attack. If they are more sensitive, it's okay, but I think every test have its own sensitivity and specificity even for the P16. يعني لو طلع P16 negative انا خلاص كده هقول مثلا ان هو مش او P16 مش cervical، لا هتقولي لا مش لازم، ده it's not 100% sure.
صحيح.
طب what about the H&D؟ فانا عايز الكومنت ده، هل يعني حتى في التريننج بتاع تلاميذكم بتعلموهم يشوفوا كويس وبتراجعوهم وبعد كده تطلبوا ماركرز، ولا نبص بسرعه والماركرز جاهزه. انا حتى اقترحت، اسف للاطاله، انا حتى اقترحت مع في الام دي بتاعي، قلت لهم يا جماعه طب قولوا لنا البانل من الاول نطلبه مع السبيسيمن اللي احنا هنعملها من البدايه، حتى لو حددتوا لي 2 3 ماركرز نعملهم من البدايه كروتين، عشان so as not to lose weight so as not to lose time. فايه راي حضرتك؟
طيب هو طبعا احنا طول الوقت يعني، وده اللي اتعلمته بقى من دكتوره ماجده، احنا بنقول ان morphology comes first. يعني هو we have to الجايد الاساسي بالنسبه لنا يكون المورفولوجي، واحنا عندنا الحقيقه parameters. مثلا لو خدنا على سبيل المثال الفرق بين السيرفايكال والاندوميتريال، there are parameters and there are some classic cases. بس the idea nowadays ان هو there are lots of in class او non classic cases. and بالعكس بقى احنا اللي we receive من الام دي تي meeting back requests، يا جماعه اعملوا لنا immunohistochemistry عشان نعرف it's primary cervical or primary endometrial, especially in some of the cases according to the different stage هو ده هيتبني عليه decision to do a surgery or not to do a surgery. It's whether it's cervical or endometrial. sometimes احنا انا ممكن اكون مياله بس الاميونوهيستوكيمستري خليني واقفه على ارض صلبه كده. يعني انا it's like I have a justification in hand, and sometimes the cases are really difficult and I cannot tell only by morphology ان هو الفرق ما بين ده وما بين ده. يعني
طب في حالات السيرفيكال كانسر اللي حضرتك بتشوفيها البرسنتج مثلا للحالات اللي بتطلب لها اميونوهيستوكيمستري كام في المية؟
دلوقتي nowadays it's definitely increasing يعني
100% مثلا.
هي لو squamous cell carcinoma it is squamous، ما فيش فيها كلام. المشكله الديفرنشيشن between endocervical adenocarcinoma واندوميتريال adenocarcinoma. اوكي، البوليسي دي بقت هايلايتد من الناس الامريكانز علشان الناس بترفع عليهم قضايا. انت قلت لي سيرفايكال وهي طلعت اندوميتريال والعمليه اختلفت and so on. So they support themselves always by an immunomarker or a panel of markers. Even and they say if we have يعني احنا عندنا الامكانيات يبقى ليه ما نعملش؟ نعمل. ما هي they don't consider this even though انا ببعت consultation لبره، اول رد ليا اول رد panel of markers، احاول اغربلهم احاول اقللهم. بس هي المشكله بقى في توجيه الماركر. صح. لازم الجولدن رول is the H&E the tissue is the issue. اوكي is the H&E. دي المشكله. المشكله الثانيه فيها الانتربريتيشن، ده لازم يبقى important، لان حاجه زي البي 16 so many people are biased by the interpretation of P16. It's not just the brown color. You have to see brown positivity في width وheight of epithelium. اوكي this is the point. يبقى انت عندك نقطه اللي هي طبعا انت عندك you are facing الايكونوميك فنفترض البيشنت هو اللي بيدفع. It's costly. It's too much. And beware of something. What you have used since last year maybe this year will not be acting. ليه؟ new markers طلعت ويقول لك لا اصل ده طلع مش بس بوزيتيف هنا، ده بوزيتيف هنا وهنا وهنا. لا، keep it aside and use this new marker. So it's a multifactorial process, but we have to so that you are giving a diagnosis that you are say 80% sure that this is
فخليني فعلا اسكن دكتور ماجده ان هو البانل اللي مطلوب اللي يطلب ده this is an art. يعني انا ممكن اطلب بانل يغرقني وبانل يدايركت مي. this is one thing. the other thing برضو ان هو يهمنا ان حضرتك تبقوا عارفين ان الاميونوهيستوكيمستري it's not a machine. يعني هو مش تيست بندخله الماشين يطلع بوزيتيف ونيجاتيف، ده في art. it's the interpretation نفسها is operator and experience dependent. ولو حضرتك شكيت في نتيجه الاميونوهيستوكيمستري you can do rereading for the immunohistochemistry still. يعني if it's not going with the clinical data and radiologic data the other H&E ممكن pathologist يعني مثلا expert اكتر يكون له رأي يعني مختلف. بس that's it يعني. Thank you so much. Any questions?